Okay, why don't we go ahead and get started? It's great to see the folks here in the audience and the folks online to this very special medical grand rounds. I'm Bob Wachter, chair of the Department of Medicine here at UCSF. Special because we have a very special guest who's Mitch Katz, who is president and CEO of New York City Health and Hospitals Corporation, which is the largest municipal health system in the United States. Mitch has been in that role since 2018, which meant he oversaw the COVID response and all sorts of other issues that confront a massive health system serving the largely indigent population of New York. Mitch has been the leader of a number of health systems. Prior to going to New York, he led Los Angeles's health system, and prior to that, he led San Francisco's health system and did that extraordinarily well. He ran the SF Department of Public Health for 13 years and was well known for funding needle exchange. He created Healthy San Francisco. He outlawed the sale of tobacco at pharmacies and was incredibly supportive of the UCSF component of the San Francisco health system, including San Francisco General Hospital and Laguna Honda. Mitch is a graduate of Yale College, Harvard Medical School. I've saved the most important piece of his pedigree for last. He was a resident at UCSF and a good friend to many of us. Did a Robert Wood Johnson Clinical Scholars Fellowship. He continues to practice as a primary care physician. He also, I believe, still is a deputy editor at JAMA Internal Medicine. So despite running the New York City Health and Hospitals Corporation, he is the deputy editor of a major journal. Just sort of take that in. And Mitch continues to contribute to the medical literature in really meaningful ways through all of this. So he's been an amazing friend to the department and someone that we're very proud of. So Mitch, welcome. Welcome back.
Thank you. Hi, everybody. Thanks again for the invitation. And I have a few goals with the talk today. One of the goals is an expression I particularly do not like is the devil is in the details. I'd like to believe God is in the details. And if you understand the details, you're in a better position to save things for people that you care about. And I care very much about the medical care that low-income people receive, and there's a lot of reason to worry about what the future might be for that. And so a key part is making sure that you understand how it's funded and what keeps it together. And I think that's particularly an issue here in San Francisco because San Francisco is a very special place. And the kind of care that low-income people get in San Francisco, while it could still be better, is very different than what happens to low-income people in Louisiana, and what happens to low-income people in all parts of the US that do not have major public hospitals. And so I wanted to make sure that you all know all of the details, understand the ways that low-income care happens or doesn't happen, so that whatever the future brings, you'll all be advocates for making sure that low-income people are protected. So being a public hospital guy, I, of course, have no financial disclosures to make. I'm not going to spend a long time on this. I just wanted to remind us, because I always start everything with mission, right? Like, why are we here? Because the largest disparities exist among people of lower socioeconomic status. And that's true of overall mortality. It's true of cause-specific mortality. And it's interconnected, right? It's lack of access to medical care. And one of my major drives in running health and hospitals is to recognize that access to medical care doesn't just mean whether or not you have insurance. So not having insurance is definitely a major problem in terms of getting health care in this country, but it's not the only problem. And part of the reason why many of the Medicaid expansions have had less impact than you might think is because there are so many other factors that affect whether a low-income person is able to get care, including their transportation, the fact that they got no one to leave their children with, that if they are going to the doctor's office, they're not going to get paid because they have no sick leave. There are restricted insurance networks, and their hospitals are resource limited. And so much of American healthcare is based, and even in places like health and hospitals, where you would think everybody would be focused on it, we're part of the American medical system too. And so somebody comes forward and is like, okay, I'd like you to come for a visit next Thursday at 2 p.m. Well, what if you, in order to have a 2 p.m. appointment, you're not going to get paid that day? Right. Most of our patients don't have sick leave, right? But we as a group of doctors and nurses and other health professionals, we just assume, oh, well, you take your sick leave. But in fact, many people don't. Or transportation. I had a patient in Los Angeles, who's a very large county, had a horrible history of a sexual assault, which was affecting her current functioning. So I made arrangements for her to see a particular psychiatrist who specializes in this. He was very gracious, made the appointment for her, and then he called me the next day to tell me she didn't show. And he went on to say, these issues of sexual assault are very difficult for people to talk about. People think they want to talk about it, and then later on they feel like they can't. I call my patient, what did she say? My ride didn't show, right? He had never really considered the idea that she really wanted to go, because if you think about yourself and your lives, if you had an appointment, and again, LA is a big county without a functional public transport system, and you had a ride and your ride didn't show, you'd call another friend of yours, or maybe you'd get an Uber, right? Or you'd find some other way. But if you have one friend who has a car and they can't come because of work, can't make the appointment. You weren't repressing anything. You just couldn't make the appointment. The social drivers, spend a larger part, if you look from certainly from a statistical point of view, are bigger drivers of low life expectancy than access to medical care, homelessness, food insecurity, lower literacy, racism, substance use, environmental exposures, having English as a second language. We have so far not been as successful at changing these things as one might like. That is to say, overwhelmingly, these are the factors that affect people's life expectancy. But when you look at the question at the other way, can we create meaningful interventions to overcome this? We're having trouble. When you look at the body of research, not a lot of interventions have been effective, and often the effect size has been relatively small. And again, I don't think that's surprising, right? And you don't overcome a lifetime of racism, social deprivation, environmental exposures in a 3-month intervention. On the other hand, it does, create a certain amount of humility about how we're going to make a difference for low-income people. But my world is mostly the healthcare world. I'm focused on social determinants to the extent that it means getting my patients to their visits, either by transportation that's appropriate or having flexible hours. But ultimately, what health and hospitals is about, medical care. What this campus is about, medical care. San Francisco General Hospital, medical care. And the largest payer right now is Medicaid. 72.3 million Americans. 79.3 million if you include the Child Health Insurance Project. And we're, as I'm sure you've read, the Committee of Congress has been given a target of $880 billion to take out of this area, which only includes, besides these programs, the only other really large program is the food program. So what is potentially a huge cut, a likely first target, although nobody knows, is the percent of a federal match, in part because the people who want to cut Medicaid will find this a more justifiable spin. The spin will be under the ACA, what Obama was able to get through. The expansion population was set at 90%. Most of the other populations, the federal government pays between about 50% and 70%, depending upon the income, the average income in that state. 90% for the expansion population. Why did they do that? They did it as an incentive to get states to be willing to expand Medicaid. The incentive worked. We're up to 40 states plus District of Columbia. The play will be, and you've already seen it in the newspaper, why should we pay 90% for a well adult when we only pay 50% for a disabled child? That's not fair. Should all be the same, which would mean lowering it from 90% to 50%. That will create a huge cut that will then reverberate through the system. The cut of the first money will be via the states because Medicaid is a federal state partnership. So what will happen is one of two things, depending upon the state. Either the state will opt out and people will who currently have Medicaid will not have Medicaid. Several of the states actually, when they agreed to do the expansion population, promulgated a rule that if the feds stopped paying 90%, they would automatically go out. So a bunch of states will go out and these people will just have no Medicaid. We'll be back to where we were pre-ACA. Or states like California and New York, I think, will not opt out. I think they will continue. They will have to put in the money. And who will be harmed? Education, transportation, food programs, along with some of the ways that state programs currently support. But nobody knows exactly, right, how severe the cut will be. Lots of different, explanations. But this would be something to watch. So this gets to a little bit of you live in a special place, and the California and New York, the two places I've worked, also have state-only expansions, meaning that uninsured patients do have some coverage depending upon the particular state and the particular issue. So in New York, which I now know best, undocumented people are covered in the hospital, not in the outpatient area. And now they're covered when they are 64 or over. So older people have been added on. California does this as well. Most states do not. So the idea is right now with the ACA covering most people who are here as residents, the states are able to then go further and do partial coverage of people who are undocumented. That is very likely to go away if the states need to put in the money just to maintain the match under the Medicaid population. A interesting group to watch, the federally qualified health centers, of which San Francisco has 11, very rich area. Federally qualified health centers have been very popular across the aisle, in part because they are less expensive than hospital-based clinics. And they are great providers of primary care. The problem with the model of assuming that, well, the FQHCs will take care of people who are low income, two problems. Specialty care, right? So federally qualified health centers, great job getting women mammograms. Bad job, what happens if there's a lump? Not an FQHC service. FQHC must see an uninsured person, cannot refuse an uninsured person. So Democrats, Republicans get to say, well, we have this in our state, we have these federally qualified health centers. and they have to see everybody. And they're getting an enhanced rate of Medicaid, meaning they get a higher Medicaid rate in order to cover that. So that's all great. But what if the woman actually has a lump? What do you do then? That they can't do. The other issue, which, and again, it's one of the inspirations for this talk about that this is a time people need to think about the details of low-income care. I'm talking to a doctor who works at a federally qualified health center, and these issues are very much in my mind. This is in New York a couple of months ago, and we were talking. I work in a public clinic, Lower East Side. He works with a very similar population. I was interested. I said, well, what do you do when somebody needs medication? And he looked at me sort of surprised. He said, well, I write a prescription. Like, well, but how do they get it filled? It's like, they go to the pharmacy. I'm thinking, I know, that even among my patients where in the public sector, medications are $2, right? I know there are a variety of reasons that still they don't get their medicines, right? And, you go with a prescription for an inhaler to your local CVS, that could easily be $90. Even some of the Medicaid patients with copays are paying those kinds of rates. So I think federally qualified health centers, a good thing, likely to be saved, likely not to be a target. But how people can at universities like this partner with those FQHCs to take care of the patients who are going to need more, challenge. So of course, as a public hospital doctor, began in San Francisco General, June 16th, 1986, my first day of residency. I have an amazing love for public hospitals. Many of them started as almshouses, which I think is in of itself an interesting piece of history, right? And tells you how people think about public hospitals, right? This is where you would send. Laguna Honda was one of the largest almshouses, right? You were at Laguna Honda because you had no money, had nothing to do with healthcare. They came around for dealing with epidemics, immigration, and over time have evolved, especially to care for people with behavioral health needs and the poor. This is one of my hospitals, Bellevue, also founded as an almshouse originally, begun, look at that date, 1736. So note that's before the Declaration of Independence. Bellevue existed. Bellevue, I took my mother for Bellevue when she broke her hip. And she's like, Bellevue, isn't that for the mentally ill? And it's like, well, yes, it was originally for the insane, as the term they used at the time. But we're currently, a large hospital, 860 patients with pretty close to state-of-the-art equipment. A hospital that you know well, that I believe very deeply in, San Francisco General Hospital, also connected to one epidemic before the epidemic that many of us served for. So originally for cholera, many of us served under the bad years of AIDS, only county psychiatric emergency department. And this was the hospital, my biggest hospital when I was at LA. But there aren't many public hospitals, right? And again, that's part of what's special and what I want you to appreciate about, San Francisco General Hospital, right? What are the other great public hospitals? So, General here, Health and Hospitals, we have 11 hospitals. Chicago has 2 hospitals. Parkland is 1, but very important. Miami still has a public hospital, some little ones. San Mateo has a Santa Clara, Contra Costa, but large numbers of hospitals do not. Why is that? Well, first, a good reason, right? More people had insurance, right? So if your view of public hospitals where people who were uninsured went, well, you need fewer of them. Better control of infectious diseases, government not a very efficient operator, large shortfalls. But what I want you to take from this, and this is very much connected to our future, even though it's going to surprise you and you're going to wonder even why I'm talking about EMTALA. But it turns out that EMTALA explains a lot of important things about the care for low-income people. So signed by Reagan, 1986. It says that emergency departments that accept Medicare, which is most, cannot deny treatment for a medical condition, basically regardless of anything, including ability to pay. Now, it doesn't mean that they can't bankrupt you. This is not necessarily free care. This is that legal, and not to say there are not violations of EMTALA, because there are, but the basic idea is they can't demand payment or to see your insurance card before they provide your emergency treatment. Now, the thing that might surprise you is that, well, this, would be something that someone like me would think is really great. And I do, but part of the harm that EMTALA caused is it resulted in a bunch of public hospitals closing. And I think I have some pictures. So think about it. Philadelphia had a public hospital. Remember, the city of brotherly love. There's no public hospital in Philly anymore. Is that because all the poor people went away? We only have uninsured people in New York City, and none in Philadelphia? No, not at all. Of course, all the low-income people are there. Well, what about DC General, famous for the number of African-American physicians that it trained? No more poor people in DC? No, that's not quite it either. What about Sacramento? What about Milwaukee? What happened to all those public hospitals, and what happened to the people who went to them? Well, part of the problem is that EMTALA gave hospitals the requirement to care for patients, and thereby gave politicians the ability to escape the cost of maintaining public hospitals where the commitment wasn't sufficiently strong. Because whatever our problems have been in the US, we're not actually a country that's prepared for people to die on the streets when we know about it. There is, sadly, the alcoholic who dies on the street, nobody notices. But in general, we are of the belief that if somebody is sick, you call an ambulance, and you take them to a hospital. That has been a basic belief about the country. Well, now politicians got to say, well, we don't have to have a public hospital anymore. All of these hospitals take Medicaid or take insurance. And besides, under EMTALA, the hospital has to take care of them. So, and I understand UCSF medical, I was told today, has more Medicaid days than SF General. And I can believe that because of the expansion population. But there are some key things that you have to realize. So, and I see this all the time in New York City in extreme cases and in minor cases. The EMTALA responsibility, besides the fact that it allowed politicians to stop supporting public hospitals and the ultimate closure, is only about emergency care, not about anything else. So you have someone with diabetes and they have diabetic ketoacidosis, and they go to one of the great public private hospitals in New York City, they're going to get great care. And I think generally they will get the same care that anybody will get. But there's no insulin on discharge. No, that's not EMTALA, right? EMTALA is getting the person back to their state. Where they get their insulin, that's a different question. And I see it operating all the time, and probably many of you do as well. Here's a more minor example from my own clinical practice, and I loved it because, again, it's sort of the naivete that people have about healthcare. A smart 22-year-old patient of mine calls me up because she was in an accident. She went to one of the great private hospitals, was seen in the emergency department. She has Medicaid, not uninsured, has Medicaid. And they, on discharge, they said, you need to be seen by an orthopedist within 1 week. And they gave her 3 numbers to call of the 3 orthopedists. It seems like a good discharge plan. So those of you who understand Medicaid access know the next part of the story. She called all 3 offices, and none of the offices will see her. And what I particularly loved about the story is she was totally clueless. As you would expect, it made no sense to her. She's like, I don't understand. They told me that I needed to be seen in a week, and they gave me these 3 numbers, and I called all 3 of them, and they told me that they wouldn't see me. Like, so the first thing before I dealt with, getting her care was I had to explain to her why it was that you could have such a strange situation of being adequately cared for, adequately stabilized, and given the right discharge plan, except it didn't really exist, right? So that's why EMTALA, is both a wonderful thing and a problematic thing. So I want to talk a little bit about, local safety net programs, because Healthy San Francisco, I think, was at its peak at 76,000. It shrunk appropriately under ACA, but we may again need local programs to grow if Medicaid is cut. And I've been a big proponent of local safety net programs. And just to talk a little, some of you may know the features about Healthy San Francisco, but to me, it fits very much with my views about the care of low-income people. New York City has a phenomenal system of taking care of people, public hospitals. We have 11 public hospitals, 5 skilled nursing facilities, 40 clinics. And long before I got there, a major commitment to the care of low-income people. But what I always ask is, well, but how would anyone know that, right? You're a new immigrant from West Africa. How are you supposed to know where you would go and how much it would cost you and what you would get? How would that possibly happen, right? You're in a new country, you don't even yet know the language or know that we have great language access. How would you know any of that, right? Or let's say you are somebody who sort of works at the fringes, you don't have insurance, you want to go see somebody, but you don't want to be bankrupt, right? You live check to check. How much would you have to pay? I don't know how much you'd have to pay. And that was actually the original idea of Healthy San Francisco. We have been able to replicate it in LA and in New York City because it's a very simple idea. All it says is take what you currently have and explain it to people and make them feel that they are entitled to it, as opposed to that they have to beg for it. Don't make them feel like they're coming to you as poor people begging for care. Give them a card and tell them this is what you're entitled to and this is how you get it and this is what it costs. So if you're in New York City Care, which is the latest, I was involved in the creation of the 3 programs, and each of them has things that they do better and worse. But if you join NYC Care, which currently has 130,000 people who have joined this voluntary program. So obviously they feel they're getting something. What do they get? Technically, they get the same thing we always had, except that now they get a card that tells them that our medicines only cost $2, that the visit itself will be free, that this is where their doctor is, they get the primary care appointment, that these are the pharmacy hours, and that they're entitled to this. This is not, and all of the various nonprofit groups in New York City, like San Francisco, is lucky to have some amazing ethnic groups, right? When new immigrants come, the first thing they do is they sign them up for the program. And they explain, and it's always, and to me, this is so important. It's always with this is what you're entitled to. This is not something that you have to beg for or plead for. This is your plan. And to try to make it as much like an insurance plan as you can. Now, of course, if you're in Louisiana, what that safety net looks like and how much you can put together, I don't really know because I've only worked in these three areas. But I think the principle is still the same, that whatever a community does provide, and every community will likely have some FQHC somewhere, some university hospital somewhere. Again, the distances may vary depending on whether we're urban or rural. But whatever you got, it seems to me you should try to make it accessible so that the people could actually use it. So I didn't want to, in the category, I didn't want to miss mentioning the disease control programs, especially because they are being cut pretty broadly. They seem to be the first things that are going under the current federal mandates about de-seeing funding. And many of these programs are very important for providing part of the care for low-income people and work especially well for those people who are on the fringes, who don't go to visits, right? So, for example, in New York and here as well, as I remember it, you know, if we have an HIV patient who hasn't followed up, we'll have the health department find them and get them back into care. But if there's nobody at the health department to do that, those people will suffer. How much will philanthropy be able to do? You know, if people assume these cuts are going on for a long time, not very much. You know, and when I'm in conversations, you know, people always raise the same ones. Well, RWJ is a major funder of health. It's not, the numbers that we're talking are in the hundreds of billions of dollars. Philanthropy does not like to take on long-term programs because it's hard for them to cut them, right? I mean, so, you know, the best ask to a philanthropist is help me create this program and let me show you how it will run if it's a success. But the worst ask is, could you, for the next 10 years, please fund my Medicaid population? They don't have the dollars and it's not going to happen. Another surprise, I think, for people to understand is who else pays for the care of low-income people? All of you with your insurance, right? And think about it from the point of view for a moment of the hospital. So this is why I spent some time talking about EMTALA. So if there are cuts to low-income people, let's say there are fewer people on insurance, or Medicaid is paying less, then the hospitals still have the same requirements around EMTALA, except now the patients can't pay, right? So Medicaid expansion is very popular with hospitals, right? Because previously they would take care of these patients without getting any money. Now, I mean, the hospitals like to complain about the Medicaid rates being low, but still it's money, right? All of a sudden that money is going to go away. Okay, well, how does the hospital stay open, right? Hospitals, currently a hospital like this gets a lot of Medicaid dollars, right? If the expansion population is decreased or lower rates, they're going to get less money. Hospital needs to have a bottom line. Hospital, therefore, has to charge more to the insurers, right? For the insured people, right? And then, you know, it's a bad cycle because, of course, if the insurer, the private insurer, has to pay more for the hospital, then the insurer has to charge more for the insurance coverage, right? That's how it works. If the insurer is charging more for the insurance coverage, then fewer people are going to be able to buy insurance, or if people have to buy insurance, they'll buy thinner insurance, right? Where, you know, they have less coverage, right? Which mostly means they won't be able to fully pay their bill, which means, again, the hospitals will get less money, in which case they will charge more money. And we're just on this cycle of more people being uninsured. So getting close to wrapping up, I think it's worth, reminding people that there is this continuum, and that when it comes to low-income people, we do through EMTALA, emergency care. Yeah, I mean, you live near a hospital, you're going to get it. Primary care depends. If you got a good federally qualified health centers nearby, you're probably going to do okay. Or if you got a public hospital. Specialty care, now you've blocked out the FQHCs, now you're reliant on public hospitals, which mostly don't exist across the country, right? So now you're mostly, begging specialists to take patients for you, or the patient is having to pay, or more likely, the patient is going without or waiting until it's an emergency. And then pharmaceutical, of which there's practically nothing, right? So other than public hospital systems that cover medications, there is no access. So I hope I've successfully conveyed to you that there, even right now, before there are large cuts, with the exception of some places like San Francisco that are very special. Although when I was at SFGH, I was hearing about the delays in getting care, and I have to confess, my system too. True fact. Right at this moment, we, for example, do no screening colonoscopies. We only do diagnostic colonoscopies after FIT tests. We're very good. We're a good primary care system. FIT tests, really high percentage of patients are getting it. Problem, any patient of mine who tests positive, 6 months to diagnostic colonoscopy. Not something I'm proud of. I'm now sort of working in a way Mark might appreciate. Mark, I'm working on the question of, why do you have to be a gastroenterologist to do colonoscopy? Why couldn't I train nurse practitioners? It's an eye-hand skill. I don't even know that you need to go to medical school to do it, really, when you think about it. And the new scopes, I don't know if there are any gastroenterologists in the room, they're all recording, so easy to do quality improvement. Why can't I get it done? Because right now in New York, with the push of colon cancer screening, a gastroenterologist can work in a surgery center, which I don't even have because public hospitals are mostly based on trauma models. So we're just now building surgery centers. And all of my anesthesiologists are busy doing trauma cases. But if you're a gastroenterologist in a surgery center with an anesthesiologist with a light hand on the gases, you can churn those patients out. You can earn $600, $800, $1 million, and you're doing something useful, right? I mean, this is not, doing diagnostic colonoscopy on patients with positive FIT. That's not an excessive service. How do I compete with that? I can't. We would pay. I have no idea what your thing is. We pay $400K. $400K in New York, I pretty much can't recruit a gastroenterologist who'll scope. So what am I supposed to do? And there's both the issue of, do I have enough money for it? And then there's also the equity issue. As a primary care doctor, we pay our primary care doctors, I think, $260, which isn't bad for us. But so do I want to pay my primary care doctors $260 and my gastroenterologist $700? No, I really don't want to. But I don't like the idea that my patients are waiting 6 months. That doesn't seem right either. So we're trying to figure out, and I've already done the easier things. Like I've said, I need the gastroenterologist scoping, let the visits be done by NPs. I already ended screening colonoscopy. Actually, Hal Yee and I did that in LA, right? It's like whatever capacity we have, we're going to do diagnostic, right? Forget that the rest of the world does screening. I can't even get near that question. So even in a place like New York City, it's not like we are able to maintain the standard. And remember that the more technical healthcare gets, and generally healthcare only gets more technical, by definition, the disparity must grow. The only way that could be a false statement is if there's a technology that makes things cheaper. Mark, out of 100 technologies that you've watched from your vantage point, how many would you say out of 100 have made medical care cheaper?
How many have or how many could?
Have.
Very few.
Very few. Right. Almost everything, almost every new thing, right? I mean, and I'll close on my own humorous story since I'm with my old friends. Turns out that it's very hard to feel as passionate about anything that was invented after you were a resident. So I offer that to the residents. So like when someone comes screaming in my office about how long the wait is for an MRI, I just think, well, I don't know. We didn't have MRIs. Hey, have you saved a lot of lives with your MRIs lately? Let's tell me whose life you saved with the MRI, right? Right, I know whose lives my trauma people have saved. And I like to say we primary care doctors, we save lives too. It just takes us a very long time. You know, you take your blood pressure medicine for 35 years and I'm gonna prevent your stroke, right? My trauma doctors, they save lives every day. MRI, I don't know. But it doesn't really matter. But the point is, we don't have enough of it. So there you have it. I hope it's a helpful summary and that you will use it in advocating for this population who really doesn't have advocates. Thank you so much.
Thank you, Mitch. That was fabulous. Let me start with a couple. You mentioned that the main mechanism of federal cuts, if it happens, will be a cut in the matching formula. Other possibilities, lower payment rates, work requirements, what else do you think like?
I think work requirements will happen. And in our non-evidence-based world, which is the one the federal government is mostly in right now, work requirements work only to the extent that they create an obstacle and so people disenroll. They do not, it's been studied, right? People have looked at this. It was done in Arkansas with a pretty good evaluation. It does not increase the number of people who are employed, right? Which is, I mean, if you wanted to say, okay, you know, you want to get people employed, you know, doesn't work. So, you know, I think that shorter, and some of these things they've already started to do, make the enrollment periods shorter, make the documentation requirements harder, right? And I think these will be the areas they will like because, again, they're a little easier to defend, right? You already hear the rhetoric. We're not really interested in cutting Medicaid. We're just interested in cutting Medicaid fraud. Okay, but think how, again, and you know, those of you who've worked, you know, at San Francisco General or in other low-income populations, getting people enrolled is not like an easy thing, right? It's not getting people to bring the correct documents. And again, differences, right? You can't say, could you just scan in your documents? And right, I mean, you're talking about people with very different cultural backgrounds and often low literacy. So they will do everything possible to shorten it. They're a little bit stuck on rates because unless they change some regs, the regs do say that the Medicaid rates have to be actuarially sound. Now, many hospitals question, well, but the current rates are not actuarially sound. So I don't know how much further push, but I think remember that when they switch the amount, what's going to happen is the bunch of states are just going to stop the program.
Right.
So just a bunch of people are going to jump off. And then, and very relevant to UCSF, I mean, think about the state of California, progressive state. I do not think that they will cut it off.
Mm-hmm.
So, but do I think they're going to raise taxes in California to pay for it? No. So you tell me, what does the state of California do? They're going to have to cut education, transportation, or other kinds of subsidies like subsidies to UCSF.
So what happens to your organization? Let's say all this happens, $800 billion cut. There's lots of people who had Medicaid last week and no longer do. First of all, there's EMTALA to all the hospitals, but then there's your place, which has its doors open to all these people. So what do you end up doing?
Well, the decision, I mean, variety of things. First, I'm trying to live each day as it comes, because I think that's always the right way. You know, I always tell people, how do you get through residency? Left, right, just keep going. That is how you get through residency. Left, right. I'm trying to say, you know, today I get up and I am going to do the best job I can do with the resources I have today for low-income people. And if I have less money tomorrow, then I'll have to get up tomorrow and do the best job I can do tomorrow for low-income people. The one decision that is made, and I always think people should live by their values, is that we will maintain one standard of care. So we will not move off one standard of care, which means that there'll be a variety of things that we'll stop providing also to insured people, because it's the only way I can do it. Well, it's not the only way. I could preferentially say, okay, for insured people, if somebody's paying, we're doing this. And if someone's not paying, we're only doing this. But, you know, my whole life in public hospitals has been about not doing that. Right. If I wanted to do that, I would be a well-paid administrator at a private hospital. I don't want to do that. And so I'm going to maintain one standard of care, which means we're going to have to do less of some of the very expensive things, including pharmaceuticals.
Let me ask you one more, then we'll open it up. This is because you're part of the family, and I want to sort of understand your career a little bit. You've kept 3 very political jobs for very long periods of time, only leaving them to take a bigger political job. You've gone through different mayors and different political trends, and yet you're very blunt and you sell it like it is, and you always have. I remember you as a resident, you always did. How have you managed to do that? How do you sort of balance that and keep these jobs for a very long time despite really changing environments?
Well,
be true to yourself.
Well, yeah. So, you know, I would offer this advice to anyone's career. The thing that determines whether you're a success in a leadership job is whether the people around you want you to succeed, right? Because one person can't do anything in a large organization. So every job that I've gone to, what I've thought about is, do the people around me want me to succeed? And how do I have it be that they want me to succeed? So how do you do that? Well, it turns out to be a very simple formula. You give all of the credit and you take all of the blame. You constantly reward the people who are doing a good job. Like, one of the things that people will tell you in my organization during the worst times of COVID, when we had to do things like, a good example was, under hospital regs, you couldn't put 2 people in a room if you hadn't yet proven that they both had COVID. So you could have 2 patients with bilateral pneumonia and hypoxia, but they couldn't go in the same room until you could prove that they both had COVID because of isolation. I'm like, put them both in the same room. You tell anyone who complains that Mitch told you you had to do it. I mean, it was a pandemic. I mean, the rules said no, but I'm like, rules in this case not sensible. So if the people around you want you to succeed because you never yell at them and you support them, which doesn't mean, by the way, I haven't fired people. That's a different issue, right? Some people are not meant for the job that they have. I think the fact, and I also recommend this, that I've always maintained a clinical practice. And that it's an important part of my identity. Mm-hmm. I think it's harder to hate somebody who's a primary care doctor, works the same, I have the same template, it's not a VIP practice. I see they put in who's ever next. And then I'm always like racing to the back of the group. I'm always like all the pictures, right? I'm always in the back. I'm never, because if you're in the front, you become the target, right? And my view is that my specialty, and again, I hope you saw it reflected in the talk, is understand the details. Don't try to be the politician, be the bureaucrat, because often there is more power in the bureaucracy. The politicians come and go, but the bureaucracy keeps moving. And if you really understand the bureaucracy, that is your best shot at helping the people that you care about. So I've tried to always understand the details, to never dress like an executive, to, I don't like the term. Yes, I don't like being referred to as an executive. I always introduce myself as the director and a primary care doctor, right? And I think that has protected me against the go after the guy in the suit in the front and assume it's all his fault.
Yeah. It's harder to go after the guy with the bicycle helmet in the back.
Exactly.
Way. Usually
Bicycle always helps.
Yeah. Let me throw it open to the folks. Yeah, and say who you are.
Hi, Mitch. Justin Zhang. I'm one of the third-year residents, as you know.
That was a nice seminar. Thanks for inviting me, Justin.
Of course. Thank you for coming. One of the questions that I have is that, especially in the new mercurial political climate at hand, and like the new director of HHS and all the anticipated CMS cuts, have you been doing anything or I was just curious about if you've been doing anything from a like political advocacy standpoint, whether that's like reaching out to your governor or like other people on a national level to figure out whether you can find some reasoning or find some compromises at hand, or has that been, or is there kind of a concern that by doing so you might be painting a target on your back or something like that? Yeah,
I mean, it's a little bit mixed at this moment. So nobody really can answer that question, because what you're asking is really what is the most effective way to counter the negative stuff going on that's aimed at low-income people, and nobody really knows. And as you've seen, the things day-to-day change, and so yes, we try, for example, there are in New York City, who are we trying to work with? We're trying to work with the Republican Congress people, and we're trying to work with them with showing them the number of their constituents on Medicaid, right? And those Republican Congress people are more important to us at this moment for saving the people we want. Right. I think how vocal to be in opposition is, again, very hard to answer. But for myself, what I don't want to do is to put a target on my patient's back for my ego. Right. And I think that, that's not an easy thing to know where the right line is. So we're still doing trans care. Several of the hospitals stopped. We did not stop. But I'm not putting out ads, to say, come to us. Now, informally, we've explained to the other hospitals and to the advocacy groups that we're still doing it. But again, I don't think it would be good for my patients if I, had ads in the newspaper, that, sticking, the federal government and saying, well, I'm doing it. I think it would just hurt my patients. So that's the line to figure it out.
Great. Thank you. Ella?
Thank you so much. Really interesting talk. I'm Ella. I'm one of the chief residents in IM right now.
Nice to meet you.
Nice to meet you. Something I was struck by was your statement about like there being power in the bureaucracy and the details. And I recently had a personal experience where my newborn daughter, due to a clerical error, was uninsured for a couple months, and trying to navigate that system as an educated physician was really challenging. And so one thing I was thinking about was I feel like this is a major gap in residency education because I had no idea what to do. And just wondering your advice for one, residents, how do you learn more about this and how do you make this part of your career? And two, then how do you translate that to your patients?
Yeah, well, again, part of this talk was the thinking that what you're saying is true, is that most people don't really understand how the health system in this country works. And that, in fact, some of the people here probably understand it worse than people in Louisiana. They probably have a better idea, right? Because they just know, well, you don't get it, right? Right. Well, here, it's a more complicated. Here, it might be that you could get it under the following set of circumstances. One of the things we joke about at Bellevue, because Bellevue's been around so long and has this complicated connection with NYU, and it's very large. And it's like, you can get anything at Bellevue. Now, do you know how to get anything in Bellevue? Maybe not. There might be one person who knows how to get a pediatric dentist who does this kind of work. Someone knows that person, but otherwise nobody knows how to do it. So, I think it should be. I mean, I think, Bob, it's a better question to you is, as, the teacher of residence, understanding how the healthcare system works. I mean, Bernie's an expert, Mark is an expert, you're an expert, and how does that get transmitted?
Yeah, it's a great question. I mean, we try, I think, but obviously the residents will know better than I do. It's often hard to get residents super engaged in it because it's one of those where until you get out of the system and it becomes a necessity, you're so busy just trying to get through your day. But left, right, yeah. The question is this left, right, or something in the middle? But I think, the lesson here is very important. This is actually, it's crucial. And I think increasingly residents are interested in advocacy. And I don't think you can advocate effectively if you don't understand the big picture.
You got to know the details.
Yeah. Another proud graduate of our residency who had major impacts in health policy. This is Mark Smith.
I'm Mark Smith. What am I, Bob? I'm a clinical professor.
Do your leather. I don't know if you understand leatherette.
I'm a clinical professor. Bob is a professor. A clinical professor is to a professor as leatherette is to leather. Sounds the same, not the same. So Mitch, first, as they say, thank you for your service over these many years. So the scenario you painted is an interesting one because most of my friends, and probably yours, think that the Maginot Line here is they're going to have these draconian cuts to Medicaid. And the poor white folks in Arkansas and Wyoming who never knew they were on Medicaid or never knew any of this are now going to be thrown off or their kid can't get this dialysis. And then they will go to their Republican congressman and they will rebel. And my question is, do you think Steve Bannon hasn't thought of that?
Yeah.
So we now see Josh Hawley and Steve Bannon saying, don't touch Medicaid. At the same time, there's an $800 billion bogey if they follow the budget rules. And it seems like they're poised not to follow the budget rules, which might put all of us in the very strange position of having the same position as the hard right-wing people who don't want to blow the deficit for our children and grandchildren. And I'm wondering what you think about that scenario, because it's hard to get, it's relatively easy to get people to march against cutting FQHCs and cutting Medicaid. But for Democrats and people who are advocates for low-income people to come out and march to protect the reconciliation rules is kind of an unnatural act. So I'm wondering what you think about that scenario that all my friends think with some glee is finally going to be their comeuppance, but might not be.
I don't think so. I'm not betting on that scenario. I'm betting on real cuts. And I'm also cynical enough to think that most people won't care. That the care of low-income people, it's just not what most people care about. And that it will be, I mean, think of how hard, we had to work to get the ACA and how close, right? If Kennedy had died 2 months earlier, there would have been no Medicaid expansion, right? I mean, the vote was that close. And so, I sort of feel like, this is, the current trajectory that we're on. What hospitals, as you know, are powerful lobbyists, and hospitals will lose money, right? I mean, if there are major cuts, right? And insurers will lose money, and pharmaceutical companies will lose money. And I think those people may be lobbying. I'm sure you read that there was a lobby group formed between pharmaceutical and insurance companies, right? So, you know, I think there is, I mean, I have more faith there that maybe the people who depend on the money may be more interested in lobbying against cuts. But I think ultimately they will cut. That's my belief. And I'm not, you know, I'm not convinced that that will be the thing that will overturn and we'll have the revolution and everybody will say, oh my God, I can't believe that the low-income people don't have pharmaceuticals. Because again, it's never felt to me that way.
Unfortunately, this could go on for hours. We'd love it to, but we need to quit. Mitch, thank you so much.
My pleasure. Thanks for inviting me.